Welcome to the ECG Management Consultants and Foley Lardner Pediatric Business and Healthcare Delivery Series. Today's topic is titled Physician-Hospital Alignment in Pediatric Healthcare, Contemporary Alignment Strategies in the Reform Era. This third session in our six-part series will present contemporary alignment strategies for the delivery and payment of pediatric healthcare services in the current health reform environment, as well as two case studies of physician-hospital alignment in pediatric healthcare. During the web conference, we also will explore the following: pediatric subspecialists and surgeon practice environment, common approaches to alignment in the reform area, specific case studies of contemporary approaches to physician-hospital alignment at two children's hospitals, and lessons learned from structural and internal alignment strategies in the two case studies. Hello, my name is Jim Lord, and I'm a principal at ECG and a leader of our Midwest healthcare practice. I'm pleased to be co-hosting along with my colleague Ken Rorda and Mark Waxman from the law firm of Foley Lardner, as well as the moderator for today's webinar. Before we introduce today's speakers, let's go over a few details about the webinar. It's 90 minutes in length. The first 70 minutes of the program is a presentation, followed by a 20-minute question and answer session. We have emailed all participants a copy of the slides that will be shown throughout this webinar. Note that attendees are participating in listen-only mode, but if you have questions, you can type them into the question and answer pane located in the toolbar on the right of your screen at any time. At the end of the formal presentation, our speakers will answer as many of your questions as possible. We will also be polling the audience a couple times during the webinar, and we hope you will participate by simply clicking on your response to the question that appears on screen. Finally, upon exiting today's program, you will be directed to an electronic survey. Your feedback is important to us, so please take a minute or two to complete this survey. Now let's meet our speakers. We're pleased to have three guest presenters joining us today. Dr. Donald Kearns earned his medical degree at the Louisiana State University Medical Center in New Orleans and completed a residency in otolaryngology, head and neck surgery at the Baylor College of Medicine in Houston. He subsequently pursued fellowship training in pediatric otolaryngology at the Hospital for Sick Children in London, England. Dr. Kearns was elected to the Alpha Honor Medical Fraternity at LSU and has been named in Best Doctors of America yearly for over 14 years. He was awarded the Master of Medical Management degree from the Marshall School of Business at USC. Dr. Kearns has practiced pediatric otolaryngology at Rady Children's Hospital for over 20 years. He has published and lectured extensively in both the clinical and administrative literature. Welcome, Dr. Kearns.
Thanks, Jim. You did well with that otolaryngology. I'm impressed.
It's a tough one for me. Thank you, Dr. Kearns. Roger Rowe is Senior Vice President and Chief Financial Officer of Rady Children's Hospital and Health Center in San Diego. Roger began his employment with the center and hospital in 2003. His experience includes positions as the Vice President for Finance at Children's Hospital in Boston, Massachusetts, the Vice President for Finance and Treasurer at the Children's Memorial Medical Center in Chicago, Illinois, the Chief Financial Officer and Treasurer at Children's Hospital in Columbus, Ohio, the Chief Financial Officer and Treasurer at OrthoExcel in Columbus, Ohio, the Vice President, Operations Finance in Brentwood, Tennessee for OrthoLink Physicians Corporation, and the Chief Financial Officer, Hospital Division in Nashville, Tennessee with Women's Health Partners. He received a Bachelor of Science degree with high honors from the University of Massachusetts at Lowell, a Master's degree in Business Administration, Healthcare Administration from the Wharton School, University of Pennsylvania, an advanced program of accounting studies at the Kellogg Graduate School of Business, Northwestern University. Roger is a certified public accountant. Welcome, Roger.
Thanks, Jim.
Dean Raposa has held the role of President and Executive Director of Connecticut Children's Specialty Group since 1996. In that time, the group has grown fivefold. In the past 5 years, it has grown by 44%. The specialty group includes 26 pediatric subspecialists, employs over 130 physicians, and 90 non-physician providers, and provides care at patient care centers across Connecticut. It provides delivery of over 240 patient visits each year in both outpatient and hospital settings. He was named Vice President, Marketing and Business Development for Connecticut Children's in August 2011. In this role, Mr. Raposa is charged with catalyzing and guiding new business opportunities, partnerships, and organizational growth programmatically and geographically for both the hospital and group. He is also responsible for the hospital's corporate communications, purchased and owned media, and the Department of Regional Pediatrics areas. Mr. Raposa serves on Connecticut Children's Executive Management Team. Prior to his tenure at Connecticut Children's, Mr. Raposa was Chief Administrative Officer at Pathwise Behavioral Health and held several management positions at Connecticut Care and Connecticut-based HMO. He earned a Master's in Business Administration from the Wharton School of the University of Pennsylvania and has a bachelor's degree from Brown University. Welcome, Dean.
Thank you, Jim.
Also with us today is my colleague, Ken Rorda. Ken is a principal with ECG and leads the firm's children's hospital practice area. He has significant experience working for children's hospitals and related institutions in both community and academic settings, spanning strategic, business, and organizational planning. He's a frequent speaker at national conferences for children's hospitals, pediatric physicians, and academic medical centers. Ken holds a Master's of Business Administration degree and a Master of Science degree from the University of Arizona. Welcome, Ken.
Thanks, Jim.
After Ken, we will hear from Mark Waxman. Mark is a healthcare partner at Foley Lardner. His practice focuses on transactional, regulatory, and contractual issues for profit and not-for-profit providers and payers. Mark's experience in this area includes issues related to the operation of healthcare systems and the integration of healthcare system participants, policy, and regulatory issues for trade associations and strategic business planning. He has a significant history in addressing the antitrust implications of mergers and acquisitions, federal program, fraud and abuse, reimbursement, and managed care contracting in the context of children's hospitals. Welcome, Mark.
Thank you, and welcome to all our speakers. We appreciate your participation.
Absolutely. Well, thank you all. We certainly have quite a panel and quite a mouthful to get through. I'm glad I got through all that for everybody, but we are pleased to have such a qualified group here. In terms of the agenda that the group's going to go through, we're going to start with some really physician-hospital alignment in pediatrics to set the stage, and then do two case studies, the first with Rady Children's and the second through Connecticut Children's Medical Center and their partnerships in various relationships. After those case studies, we'll leave ourselves some room for some conclusions and then ultimately get to a good question and answer session and dialogue with you all. So, Ken, I think you're starting us off in section 1.
Thanks, Jim. I'll be brief in my comments and introductory comments because I know everyone's anxious to hear about the case study examples. But most of you, I'm sure, are very familiar with the drivers of alignment in the current environment. The key here is we've heard a lot in the last several years about healthcare reform influences, but the fact is we've been aware of factors that are apparent in pediatric healthcare, in particular pediatric subspecialty in surgery healthcare that have been present for much longer. And those include predominantly financial pressures, but related to downward pressure on professional fees as commercial insurers consolidate and exert more pressure, and as Medicaid programs with the economic downturn have cut programs or have tried to keep costs in check. We also have had a long-term shortage in physicians in key subspecialty and surgery areas that have led to escalating salaries. Demand, pure supply and demand, the supply just isn't quite there given the amount of care that we need to provide to these sick kids. As a result, the cost of professional practice, the difference between pro fees and actual costs, strong component of that being physician compensation, has grown. The gap has grown, and it's developed into a reliance on other sources of funding for the pediatric physician enterprise. Depending on the environment, that could be university, hospital, other outside external sources, extramural research funding, etc. In addition, in the near term, in the last several years, we've seen thoughts and plans, in particular on the adult side, around the emergence of global payment systems with the Medicare ACO efforts, pilot efforts, and other efforts by commercial insurers to look more closely at global payment systems and care delivery reform. So with all of those factors, we continue to have in pediatrics the driving together of physicians and hospitals and the need for better alignment. The organizational constructs then are dictated by a number of idiosyncrasies, depending on in large part, depending on the existing organizational constructs. And in particular, as you all know, a large proportion of our healthcare is delivered in freestanding children's hospitals. Two good examples of that today. But then there's a strong component or a strong contingent of children's hospitals that are within hospitals, either within academic medical centers or within larger health systems or adult community hospitals. Additionally, you've got specialty hospitals and then other pediatric units or programs that exist within community systems that are tied to labor and delivery and women's programs. The group structures then, as Mark is going to get into a little bit, is dictated to a degree by legal requirements and regulatory requirements that can be state dependent. But we see a broad spectrum of structures, including those pediatric physicians that are within practices that encompass both adults and children. We also have the growth of employed physician networks within some children's hospitals where states allow it. We see multi-specialty practice plans or freestanding medical groups that are pediatric specific. And we also see a number of other structures depending on what the local environment is and depending on the relationship with the academic medical center, school of medicine, and adult practice plan. So traditionally, though, we've seen alignment mechanisms go in this graphic from the left to the right. We've seen the traditional mechanisms of medical directorships, payment for call, as extensive as clinical joint ventures between physicians and hospitals. But increasingly, in the last probably 5 to 10 years, the growth of those more integrated structures, including employed multi-specialty groups, medical foundation models, as we'll hear from the Rady folks today, but then other better aligned structures, including practice management arrangements or other employment type arrangements. Above all, we see, I think, a mix of all of these things, and increasingly in those areas where you have a mix, the need and the pursuit of better alignment. As we think about true alignment in the current environment, though, it stretches beyond finances, it stretches beyond organizational constructs to encompass essentially really 4 main spectrums. We like to think of it as encompassing, first of all, the integration of leadership. So what we've seen is the growth of physician administrative positions within children's hospitals and programs, the overlap of academic, clinical, and hospital administrative positions, the emergence of the roles such as surgeon-in-chief of the children's hospital or pediatrician-in-chief, the growth in the number of physician CEOs of children's hospitals or children's programs. These are all mechanisms to integrate leadership at the physician, medical school, research enterprise, and hospital levels. Obviously, financial integration is a critical component, given that a lot of these pressures are financially driven. But essentially what we're seeing is a move towards incentives that are aligned. So movement away from structures where the hospital has one set of incentives and the physicians have a different set of incentives financially. Organizations are trying to align those and pursue structures that align those better. Next is strategic integration. In a number of places, you still see separate strategic planning that occurs in the physician enterprise as compared to the hospital. In the best aligned and most aligned organizations, you have joint processes or single processes by which strategic plans are developed and pursued, given that we have the need to integrate and the need to align those strategies and tactics in order to accomplish them. They have to be consistent on both the physician and hospital side. And then finally, physician organization, which is, I think, the tip of the spear. It's where we start with a lot of these discussions. What you're seeing is a move from fragmented and multiple group structures, which still exist in a number of children's hospital and pediatric program environments, a move towards more consolidated practice structures where you have some group practice organizational constructs that allow for better management, better alignment of strategic goals, singular alignment of strategic goals among physicians, and those sorts of things. So with that introduction, I'd like to turn it over to Mark. He's got a few comments to make, I think, around the legal constructs and other legal considerations before we get to our guest speakers. Mark?
Sure. Thank you very much. Appreciate the introduction. And, what we've heard from Ken is a general overview with respect to sort of what's happening on the ground. There's an awful lot of activity. And what I want to do is just add a brief legal perspective to it. I'm sure, as everyone on the call knows, whenever there is activity in a regulated environment where reimbursement is at issue from state or federal sponsors, and increasingly on the private side, there are a variety of legal issues and hurdles to work through to make sure that whatever the alignment structure you create sort of passes muster across the board, ranging from the simple to the more complex. I like to look at it as a situation where those involved in sort of bringing alignment have a toolbox that they think about of a variety of tools that have both structural and financial elements, and then you look at the tools available with the goals that you're trying to achieve and figure out, well, what's the best way for us to blend sort of the strengths of what we're trying to do, avoid the weaknesses, and make sure we get paid in the process. So if we think about the range in the toolbox, everyone's pretty familiar with the fact that hospitals in particular, but also group practices, are involved in employing more physicians as one way for alignment to take place, or acquiring more practices. And so one needs to be careful to make sure that, to the extent that you're having people as independent contractors but treating them like employees, really, that you follow the rules with respect to that. And the prices you pay for practice acquisitions are appropriately determined under the applicable fraud and abuse laws. People create aligned practices. Those of you who have been doing this for a while know there's these Fenley PC models, hospital-owned physician groups, faculty practice plans, each of which has different pluses and minuses depending on the cultural attributes and attitudes of those who are participating, and whether there are corporate practice issues in the particular state which you may find yourself. We have a foundation presentation today. Many states allow for certain kinds of foundation models of practice, which is a way of bringing physicians together in a corporate form and typically providing an exception to the corporate practice of medicine. California has its own specific statute, 1206L, in the Health and Safety Code. Texas has its variation. Other states have their own. Licensing issues with respect to clinic models are important, again, as exceptions to corporate practice of medicine rules, and create their own reimbursement environment. And as people talk about joint ventures or other types of contractual arrangements, there's a variety of issues that you think about, ranging from governance, how's what we're doing going to be governed, to licensing. Have we created something that will be licensed as a provider, so it may be paid as a provider, to the fraud and abuse laws as we move money around those who are participating, to the tax code. Most of the pediatric world consists of not-for-profit providers on the institutional side, and often for-profit providers in the sense of physicians who are not part of a faculty practice plan or employed by a not-for-profit entity, or on the for-profit side. Bringing those models together requires a review of the tax code and the requirements for joint ventures or contractual arrangements, with a variety of limitations to consider, from sharing of net profits being an issue to the length of management agreements in bond-financed buildings. We have lately seen sort of an increased level of sophistication as we look at medical homes creating, management arrangements in physicians for patients who may also involve not-for-profit providers in the sharing of funds, all the way up to the ACOs, where questions are, what license category is an ACO if it's going to receive funds on a risk or even collaterally on a fee-for-service basis. And then we want to make sure that people who come together where they were competitors don't come together and fix prices or carve up markets or run afoul of the antitrust laws. Those of you who are adjuncts or hooking on to a second-tier or third-tier contractors to ACOs or pioneer ACOs know that it was possible to get an antitrust exemption or a quick look that said there wouldn't be an antitrust issue with respect to ACOs, but those are governmental programs for the main part. As we look at pediatric ACOs, that regulatory framework has not come into existence, and so people are simply creating them in the commercial markets or as part of Medicaid plans, all of which require review to determine whether there are antitrust issues as competing providers come together to think about various issues in their pricing and the division of dollars that are going to flow through that system. So as we sort of push forward into these areas, it again becomes important to focus on each of these types of issues: licensing, antitrust, referral or fraud and abuse laws, tax, and reimbursement as you look at each type of particular arrangement. Alignment, often takes place at the financial level, if not necessarily at the governance and structural level. So now we're seeing these kinds of things: bundled payments, or episode of care payments, percentage of premium or capitation carve-outs for pediatric or certain types of children's care, on top of or often in conjunction with pay-for-performance bonuses that are looking at quality, cost, and efficiencies. All of these programs in financial terms are ways to move money away from a fee-for-service payment, which had a regulatory framework that's fairly straightforward, pretty easily understood, to now where people are getting monies for more than what they perform typically, but will also involve others. How those dollars are shared, allocated, moved around a system, all require a review to determine that we're not running afoul of payments which may not be fair market value. That may be okay depending on the state and federal program involved, or it may not. Issues related to, are we paying for services plus management, and is that acceptable? Are we requiring referrals as part of a closed system? All of these become issues as we look at these sort of alternative alignment strategies where we use financial tools to drive or help drive clinical alignment. And again, just to review the bidding here, these are some of the key issues that you look at, particularly when you're combining not-for-profit, for-profit entities. The kickback statute is fully applicable to Medicaid, SCHIP, state-sponsored programs, federal-sponsored programs, unless there is a specific exception that has been requested and received. Issues related to the antitrust laws must be reviewed, but we all, at least in this area, give a great sigh of relief that the Stark law actually applies Medicare only and would not be an issue that we need to look at when we think of Medicaid or a number of other state-sponsored programs in this space. So I think this is kind of a background to say, look, there are a lot of tools. They're increasingly being deployed into the pediatric and Medicaid space. But as one deploys those tools, we need to be careful that we can meet all the requirements of licenses for the arrangements we want to create, as well as these particular issues. And with that, let me turn it back to our moderator.
Okay, thanks, Mark. Let's launch our first polling question for the audience, which is on your screen now, and it is, which physician hospital alignment vehicles are you currently pursuing? Please select all that apply. Employment of subspecialist surgeons, employment of general pediatricians, joint ventures, redesigning financial arrangements to align incentives, other vehicles or structures. So we're getting get our audience to answer some of these questions. I don't know, Ken or Mark, do you have any way you want to handicap this as we wait for the audience votes to roll in?
It's always dangerous to comment before the results come in, but
True.
You know, you could almost put an all of the above on here, and it would probably get you know, a fair number of responses as well. The joint venture discussion, you know, that can appear in a variety of ways. The traditional joint ventures probably are a little less prevalent just because the facility type services that you see joint ventures in adult medicine aren't necessarily apparent in the same volumes, and so probably don't produce the same results. But joint ventures around billing groups, around clinic management, and those sorts of things, I think if we were to dig deeper, we might hear a little bit more response from our attendees in that regard.
Okay, let's go ahead and close the poll and see what the answer is. Looks like we have about 50% saying employment of subspecialists and surgeons, followed by 44% both in redesigning financial arrangements to align incentives and other vehicles, than employment of general pediatricians and joint ventures. Any reflections on the results? Ken, you want to start us off?
Yeah, the fourth one, as I look at it and think about it, indicates that to a degree, probably some of our attendees are comfortable with structures, but not necessarily comfortable with how the financial arrangements have been set up. And then the employment, the fact that the employment questions are as high as they are is probably not a surprise, although as we'll hear from the Rady folks, some states you just can't employ, and so there's some people that wouldn't have indicated that just simply because of where they live.
I think it's interesting. The other vehicles or structures is as high as it is. So it just shows you, as you look at this, that an awful lot of activity going on as people try to adjust to the changing marketplace.
Yeah, I think you're right. I think it's a good point. In the adult world, you would see that filled often by a lot of the focus on clinical integration, which you guys touched on as well. So maybe those beginning ACOs and clinical integration makes up some of that other 44%. So it was good. Let's move on. Okay, actually, Dr. Kearns, I believe we're coming to you.
Terrific. Are we ready to go here?
We are.
Perfect. Okay, well, let's see. This is a complicated, let me just preface my remarks by saying that Roger and I are going to do this together, and I think you'll be able to tell the difference because I'm the one with the Cajun accent, and Roger is the one with the Bostonian accent. They're fairly different. So this is a fairly complicated slide, and I think everyone involved with public speaking says don't complicate your slides, but it's been a complicated story, and I think as has been mentioned previously, and as we're probably going to harp on, the entire idea of bringing together groups and aligning vision is a complicated story and ends up being fairly local. So it really depends on your local politics and who you've got involved. Historically, UC San Diego got started about the same time as Rady Children's Hospital. So both institutions were started probably in the early 50s. Children's Hospital at that time was actually a polio hospital. And Children's Specialists of San Diego has gone through a variety of different name changes, but it started probably 33 years ago or so. It was basically a group of subspecialists who provided care to children at Children's Children's Hospital. The integration of these three entities has certainly been in the back of everyone's mind this entire time, and through a variety of different ways that did occur slowly but surely, and Roger's going to walk us through some of those. But it was not done without a lot of gnashing of teeth, shall we say. So UCSD Health Science is a large academic medical center with 2 hospitals. Its medical school is ranked 6th among public schools for research. It had at the time 16 pediatric divisions, and prior to the integration, 54 pediatric academically oriented physicians. So these were physicians who were primarily researchers and did a small amount of clinical work. Children's Specialists of San Diego was a for-profit medical group with 25 divisions, 146 physicians. We were the primary provider of pediatric subspecialty care for the greater San Diego area and the region. Our physicians were involved in clinical research and actually provided the vast majority of training for the trainees, both medical students, residents, and fellows who were affiliated with UCSD. The vast majority, if not all, of the Children's Specialists of San Diego physicians were on the faculty of UCSD as voluntary faculty. Rady Children's Hospital is a large freestanding children's hospital serving the region. At this time, at the time of the affiliation, we had 297 staff beds. We're nationally ranked. Significant clinical research through Rady Children's Research Center was being performed. And basically, at Rady Children's, we provided the vast majority of training of fellows, residents, and medical students in the area in pediatric health care.
So our case study here at Rady Children's is about the creation of a medical practice foundation. And Ken explained earlier that in California, we're one of the states with a corporate practice of medicine law, and so we're not able to hire physicians. And so the foundation that we created is the one that Mark introduced us to a bit ago, is the 1206L Foundation. But before we get into the creation of the foundation, it's important to step back and understand a little bit more of the history. And in 2001 was when Rady Children's, the University of California San Diego School of Medicine, and CSSD first signed a formal affiliation agreement. There had been at least a 2-decade effort to pull that together, and it didn't really come together until 2001. Rady Children's, and I should say it was at the time Children's, it didn't adopt the name Rady until 2006, but Children's Hospital's main goal in this affiliation was to take advantage of bringing together itself, an organization with very strong clinical programs, and UCSD, an organization with very strong research programs. So the Children's Hospital, strong clinical programs, much lesser strength in research, and UCSD with very small pediatric program and huge strength in its research. The goal was to bring those 2 organizations together, and that was done in August of 2001. And when that occurred, UCSD, the programs are all consolidated onto the Rady Children's campus. And so at that time, UCSD had an approximately 8–9% market share, and that portion of the business moved from UCSD to Rady Children's. The affiliation also brought with it a change in the governance of Rady Children's. We had at the time and still do, an 18-person board of trustees, and with the affiliation came an assignment of 1/3 of the board seats to positions that are nominated, by the university and ultimately appointed by the Rady Children's Board. Some of those positions are there by position, such as the Dean of the Medical School, the Chancellor of the University, and a couple of others, and some are, again, appointed by the university. In return for the programs moved to Rady Children's, and in return, Rady Children's provided support and still provides support to the university financially to support its academic programs. There's a formula that defines what that funds flow is every year. It's a formula that was in place in 2001 and remains in place today. And maybe I should say that both sides, UCSD and Rady Children's, equally dislike the arrangement, and so that must mean that it's equally satisfactory to both. Some of the challenges that were associated with this amalgamation were that the typical town-gown relationship, the clash between the clinic and the academic faculty. There was constantly competition over recruitment of physicians, and we'll talk a little bit more about that later on. That really continued until the creation of the foundation. The creation of the foundation really was important in helping us deal appropriately with some of these challenges. And I think we'll move on from there. So, again, because of the corporate practice of medicine law, we created the 1206L Foundation, and actually Ken Rorda and I have given a presentation on what the requirements are and what the characteristics are of a medical foundation, and we're not going to get into today all of that, but if you were interested in that, Ken or I could share that with you. One thing that's important to understand, and not everybody knows this, is that the Medical Practice Foundation does not need to be a separate corporation. And in our case, the foundation is not a separate foundation. It's actually a division of the hospital. And the foundation has its own governance, and we're going to get into that in a little bit. But that governance, again, is part of the hospital management structure. The foundation itself does not employ physicians, consistent with the requirement that we can't do that, but it contracts with them. And so our foundation contracts exclusively with Children's Specialists of San Diego, CSSD, to provide services to foundation patients, and they in turn provide their services exclusively to us. So it's a mutually exclusive relationship. A foundation can also, and ours does, have risk-bearing arrangements. And so one of the challenges that we had in creating the foundation was that we needed to cancel all of CSSD's contracts with third-party payers and enter into all new arrangements. And what made that particularly challenging, as I think the audience might appreciate, is that as we were negotiating the foundation, as closely as 60 days prior to its actual go-live date, we weren't exactly certain that we were going to have a foundation, whether we would ultimately negotiate all the fine points. And so we really couldn't begin the managed care contracting until we knew that it was going to happen. And so our managed care contracting department could get ready, could position themselves, but really couldn't begin to do the contracting until we actually knew we would have a foundation. The last point is that the foundation does have to conduct medical research. That's one of the many requirements of a medical foundation in California.
So with this construct, how did we go about doing this? And one of the things we recognized was we were going to have to get back to what we were and where we wanted to go. And one of the initial meetings was basically to create an aligned vision. We were able to integrate and collaborate in fulfilling the missions of both Rady Children's, UCSD Health Sciences, and Children's Specialists of San Diego. The purpose, of course, was to improve patient access to care and physician recruitment. One of the biggest challenges, as Roger mentioned, was physician recruitment. And in the model post-amalgamation of the hospital and the university, we were still left with competing medical groups, i.e. the university employed some clinicians to provide pediatric health care, and CSSD did also. And although we were supposed to be somehow related to each other, we seemed to be competing for the same physicians. And a physician would come in to interview and would interview with the CSSD doctors who'd offer him a job and the UCSD doctors who'd offer him a job, and they would take a look around and realize we didn't know where we were, and they'd leave. So we were having significant problems both with recruitment and retaining talent. The foundation allowed quality and delivery of care to be aligned in outpatient hospital settings. It was huge in being able to allow research infrastructure for both the CSSD doctors and access to patients for the UCSD doctors. It allowed us to optimize training opportunities for all pediatric specialties, both surgical and medical, and it improved coordination of payer contracting. It significantly simplified professional malpractice and compliance.
So as we were forming the foundation, we asked ourselves, and actually our board asked us, how will we know after some period of time, how will we know that the foundation has been successful? How do we measure success? And you can see the several measures on this slide. I'm going to speak to a few of them. The first one talks about having a highly functioning entity to carry out the various businesses of the foundation. And I think one of the points I would want to make here is that our Board of Governance Committee, and Donald will explain this a little bit more in a few minutes, but the Board of Governance Committee is a 15-member group that is comprised of 11 physicians and 4 members of management. It was very important to us to have this committee heavily physician-dominated, and it's worked very well. And I think the important point I want to make to you is that during the first 3 years, and we're approaching the end of our 3rd year in the foundation, there has never been a vote, an action taken at one of the Board of Governance Committee meetings that has not had a unanimous vote. That's not to say that we don't have disagreements. We have disagreements. We have issues. We work through them. We resolve them. And ultimately, at the end of the day, we hold hands and make sure that it gets done. We are very fortunate here at Rady Children's of having a medical group that works very collaboratively with us. Donald mentioned, our vision was to recruit the best and the brightest, and we had set a target for ourselves to, within the first 3 years, recruit a net increase of 30 physicians. And we achieved an increase of 32 physicians in 2.5 years. And that is probably the most significant success point that I would make. Attracting, retaining physicians in Southern California in a pediatric practice is a very difficult thing to do. We have a combination of perhaps the worst Medicaid rates in the country for a practice that's about 50% Medicaid, and a very, very high cost of living. So low reimbursement and high cost of living is not a great recipe for attracting and retaining physicians. And the foundation has helped us to do that, in part because we've been able to, with the contracting, we've been able to use some leverage there to improve the rates that we're getting from third-party payers. I want to talk next about the access goals. We've made some improvements in access, but we've made it a major goal for year 4 of the foundation. And the physicians have really embraced this goal and have actually hired a consultant to help them with access. and we're going to measure access as third next available new appointment. And we are so committed to making this a real success that we have incentivized the physicians and the physician group, CSSD, in the coming year to the tune of $1 million if they meet the targets that we've set for patient access. The granting of that possible incentive payment to them comes with their needing to pay us up to $1 million if access deteriorates. So it's a payment in either direction, and has us all highly motivated to improve access in the coming year. And you can read the others there. I want to speak to one other goal or measure of success that isn't on the page, and that is that the PSA, the Professional Services Agreement that we have between the Foundation and the medical group, has a 10-year term. And within that, there are three-year terms for the financial compensation arrangement. And the agreement called for having the new compensation arrangement decided 60 days prior to the beginning of the fourth year. And the beginning of the fourth year is July 1st, 2012. And we achieved that. It was about a 5-month negotiating process that we had between the group and the foundation, but we were successful in achieving a renewal of our second 3-year financial arrangement on time.
So again, Roger was talking briefly about the professional services agreement and the agreement between CSSD and the hospital. This is a complicated slide because it ended up being complicated. It's the foundation itself is a division of the hospital. The foundation has an agreement with CSSD. CSSD has to have an agreement with UCSD. The vast majority of the physicians who are work in the hospital are UCSD faculty. Not all of them, and the goal is to have everyone who was in the prior CSSD become salaried UCSD faculty. Everyone is on the faculty, but not everyone is salaried. And there are some exceptions. I think there are 5 or 6 of our physicians who are not, and the vast majority of that is due to people close to retirement along those things. So we look at being 100% UCSD salaried faculty very, very soon. And then, of course, there's an affiliation agreement between the hospital and UCSD. Now, how do you govern something like this? The way we were able to, and this is what we call back home making sausage. It was a long process trying to figure out exactly how we were going to agree to govern the entire group. And although it seemed we spent an inordinate amount of time and there was a lot of misery putting this together, as Roger alluded to, once it got in place, it's been singularly successful. The Board of Governance Committee consists of a variety of physicians who are actually on the ground, people, as I say, plowing the fields every day. The surgeon-in-chief, the physician-in-chief, the executive director of the medical foundation, and a number of administrators from the hospital. In practice, there is also a Board of Governance operating committee. And so the operating committee meets every week and actually is able to get whatever we need to have done in a business way done on a weekly basis. Then we report up to the Board of Governance Committee, which initially met twice a month and is now meeting once a month. The foundation itself, as a division of the hospital, actually answers to the hospital board. So the true board for the foundation in the end ends up being the hospital board. As far as quality and as Roger had mentioned, access and the medical group continues to manage that and actually has a clinical board which continues to meet as part of CSSD. And as I mentioned previously, the vast majority of our physicians are UCSD faculty. So of course, as UCSD faculty, we answer to the dean at the medical school.
So what would we tell you about our experience as we reflect on having this model in place now for a few years? The first thing we would say is that this model has worked very well for Rady Children's and for the UCSD School of Medicine and for the Children's Specialists of San Diego. It's worked very well for us. That doesn't necessarily mean that this model is one that's right for everyone. I think every situation is different, and every situation requires a careful review to see what would work best. In our design, we of course have still have the medical group, and one of the things that we like is that the group, with the creation of the foundation, the group continues to exist. So we, the foundation, compensate the physician group for all of the services that they provide to the foundation. And one of the, I think, nice attributes of this is that it keeps hospital management out of deciding physician compensation individually. We decide, and we don't decide, we negotiate the compensation to the group, and then the group can decide how it wants to pay individual members and individual divisions. Would also say that you need to have individuals involved with your organization who have strong group practice management expertise. There were some of us on the management team who had some of that experience, but we, I guess, knew enough to know that we needed to bring in people who had that specific expertise to an extensive amount. And so as we designed the foundation, initially we had working with us an individual who had been the chief financial officer of another very large 1206L foundation here in California, and his assistance was critical in the beginning. And then on an ongoing basis, we hired an individual from the Scripps Clinic as the chief operating officer, and an individual from the Cleveland Clinic as the chief financial officer. And their expertise, I have to say, is critical. What has been critical to the success of the foundation. We couldn't have done it without them. At the outset, the commitment at all levels of the organization was essential, especially at the top. And this came together in 2009 because in particular, three individuals: the dean of the medical school, who was relatively new in his position; the CEO of our organization, who was at the time in her third year of tenure; and the newly minted CEO of the medical group. So we had three individuals new in their positions who are all absolutely committed to making this happen, and were great in knocking down barriers as we negotiated issues along the way. The reaction from the community was more than we had expected, particularly since, if you remember, we created this foundation in 2009, but we had affiliated with the university in 2001. The affiliation with the university didn't bring much of a reaction. This creation of this foundation brought a very significant reaction in 2009 because, and I think, Donald, we haven't made this point yet, that all of our physicians through this structure became employed by the University of California. And when the community organizations realized that that had occurred, they saw Rady Children's as aligning significantly with one of the health systems in town. And we had always enjoyed, Rady Children's had always enjoyed a relationship with the major systems in town. The major ones are UCSD, the Scripps system, and the Sharp system. and we had what many in the children's hospital world call a Switzerland-like relationship. So great relationships with anybody, no strong relationships with anyone. But some of the systems in town saw this connection with UCSD as significant and perhaps in some ways a threat to them. Perhaps demonstrated most dramatically by in a situation where we had been providing neonatologists to one of the systems, and that system said that because those physicians were now going to be employed by the university, they did not want to extend that contract, and they terminated the contract. So we lost with that a dozen of our 30 neonatologists, which was very unfortunate, and it has really been the only significant loss of physicians that we've had. It's actually the only loss of physicians at all that we've had as a result of any reaction to the foundation, but that was significant to us. The negotiation took was a lot more time consuming than we thought it would be. We planned that it would take about a year, and that it would take a third of the time of some of us in senior management. It took a year, but it took 75% at least of the time of 3 or 4 of us. And in the medical group, I know their leadership spent maybe close to 100% of their time in some cases. But that goes to the last point, that the short timeline, we all agreed we would get this done within a year. Had we not said that we would get it done in a year, we may still be negotiating. We worked very, very hard at this, including 2 all-weekend retreats to negotiate issues, so very, very time-consuming. So looking back now, after the 3 years of existence, we've talked about outcomes on the left-hand side, how pleased we are with the recruitments that we've had. We make the point that we're financially sound. The first year and a half or so of the foundation were financially very, very challenging. We were sufficiently concerned about the performance that we brought in an outside group to do a diagnostic of our performance, and they came up with a number of very good recommendations. And during our 3rd year of the foundation's existence, we're actually outperforming budget by a fair amount. We're better integrated with the medical school, and the extramural funding for research has increased significantly. The integrated approach to planning that we have with the group is maybe worth taking a moment to pause on. The CCS pilot is going to be our first stepping into an accountable care organization kind of arrangement. And so we're entering into, with our partners in the medical group, the foundation is entering into an arrangement with CCS, which is California Children's Services, for a pilot program with the cystic fibrosis population. And that's not a huge population, but as you all know, very resource-intensive population, and looking to take a more holistic approach to treating that population of patients. We like the idea of doing it one significant diagnosis at a time and learning through that rather than jumping into it and perhaps losing significantly financially from it. The model gives us the potential for greater integration with primary care, and we haven't talked about primary care yet. Let me tell you what our relationship is today, what our arrangement is with the primary care physicians in our community. We have a subsidiary at Rady Children's that is an MSO that is managing a group of 80 pediatricians in about 20, 21 locations throughout greater San Diego. And that's an arrangement that's been in place for about 10 years and has been very successful, I think, for both the physicians and the primary care group and us. And we have talked about maybe someday bringing the primary care group into the foundation or creating a separate foundation, which might actually make more sense, but we're not at that point yet. And I guess perhaps further discussion on that at another time. What have we learned? I think I talked about the strong leadership being critical to getting this thing off the ground, and then strong leadership very important in being able to manage it well as we moved forward. The adult systems, I gave you one example of a reaction that we had, and that was greater than we had anticipated. And so if anybody were to think of setting up a similar model, one piece of advice we might give would be prepared for that. I would also say, and we've asked ourselves this question, had we anticipated it, would we have done anything differently? And the answer is no. We believe that we did this in the best way for Rady Children's, and for the group, and for the patients that we serve, and that's what's most important. And so the adult system reaction is unfortunate, but again, we wouldn't have done anything any differently. It may not be possible to bring everyone along at once, but we did, and some came kicking and screaming. Some were less, but they were truly a minority, and I think that they're happier today. We didn't bring the pediatricians along, as we said, the primary care, and that may come at a later date. The last point to make here is the importance, as you go through this, of having qualified advisors. And I'm going to mention in no particular order the advisors that we used and why they were so important. The attorneys who we used, both that the medical group used and that the hospital used, both had significant experience working with 1206L foundations. Perhaps an interesting point, we both chose first the same attorney without the other knowing it. And so that was a point that we conceded to the medical group. We allowed them to work with that firm, and then we found another firm that we were equally happy with. But we thought it was interesting that we both initially came up with the same attorney. Compensation, obviously very, very important, and the compensation consultant that you use in creating an arrangement like this, or actually for any compensation arrangement, is very, very important, and you want to make sure that either they or somebody else is fully prepared to give you a fair market value opinion on the compensation arrangements that you come up with. And lastly, the operations and finance, I think I've spoken to that already, but just in getting it set up initially, how to best do that, and as we were pulling it together, extensive financial modeling, and then as we got it going, of course, the financial management of the ongoing enterprise. I think at this point, I'm going to pass it back to Jim to launch the second poll question.
Yeah, and that's on our screen now, and that question is, how are you achieving financial alignment between your children's hospital and physicians? Please select all that apply. Is recruitment and support of physicians, paying for physician time through things like directorships, ongoing subsidy of clinical practice, investment in research time or space, creation of hospital leadership positions. We're going to give people just a bit of time to answer, so I'll ask you to get your answers in here pretty quickly, please. I have to say I'm so happy you guys addressed the community reaction. As you were talking early on, there's a lot of questions coming in about that, and you guys completely addressed that. So, as all good presentations, you anticipated what everybody thought, or whatever questions would be. So nice job. I'm actually going to go ahead and close the poll. And those answers are now on your screen. Looks like about half are recruiting support, or using recruitment support to physicians groups. About 68% paying for physician time through things like directorships. Ongoing subsidy of clinical practice comes out at about 45%. Investment in research time or space, much lower than anything else, is about 14%. And creation of hospital leadership physicians, almost 60% at 59. So interesting reactions from the group. I think I'm going to turn this back now to Dean and ask that he give us the Connecticut Children's and the Connecticut Children's Specialty Group story. Dean?
Thank you. Thank you. I think the folks will see some interesting parallels between our experiences and our responses and Rady's. So we'll move right through this. First off, our organization or organizations, Connecticut Children's Medical Center, is the only freestanding children's hospital in Connecticut. It's now 16 years old. It was built and established in 1996 and was the product of 3 separate enterprises. There was a Newington Children's Hospital about 10 miles south of downtown Hartford, where we're located. That was not unlike some of the origins the Rady folks spoke about, was a polio hospital, or hospital for, it was originally called the Hospital for Crippled Children, and they had some subspecialties, most notably orthopedics. Hartford Hospital had some pediatric subspecialists in their hospital, within their hospital structure, and the University of Connecticut Health Center had other subspecialists. We were fortunate that there were only a couple of subspecialties that had any overlap, so they were mostly mutually exclusive. So, for instance, ortho only at Newington Children's. And so it was the vision of many of the pediatric subspecialists in each of those places to come together and have a children's hospital that would be a full-service hospital, and was realized in 1996. Children's has 3 subspecialties ranked in the U.S. News and World Report for best children's hospitals currently, and we hope to have more in the near future. Connecticut Children's Specialty Group, 25 pediatric subspecialties, including both medical and surgical, and I think that's where we're pretty distinct from many other such groups. Most other children's hospitals that have groups organized tend to have a medical group and a surgical group, or multiples thereof. So the fact that we're organized across the medical-surgical divide is relatively unique, and I think is a relative advantage and strength. 140 employed physicians, 229 clinicians, including mid-level providers, and we're the Department of Pediatrics for the University of Connecticut, and training medical students, residents, fellows, etc. We've seen a recent growth in fellowship slots, and I think we're both going to emphasize the importance of recruitment and retention, and one of the reasons to do fellowship is for professional satisfaction for our folks, but it also is a very important potential pipeline for future talent to your organization, so we recognize that as well. The university supports research among faculty, and they have a recent affiliation with Jackson Labs, which really is a huge game changer for us, and will result in $1 billion investment in research, focusing in no small part on genomics. Next slide is some of the history through the years, but I want to point out that really it was a recurring theme of integration. You know, our initial birth was the fact that we're a product of the integration of 3 separate entities, and it just continued and continues on that way. And I think that's also an important cultural factor for us that I think we can leverage down the line. So both the hospital and the group were incorporated in 1996 and began operations, and we talked about the different entities and the surgery and urology group. We integrated subspecialists in 2002 from 3 disciplines, and actually, to be more specific, those were the disciplines that had been at the University of Connecticut Health Center and came to our hospital but until 2002 were not formally integrated into the specialty group. They operated autonomously within the walls of the hospital. In 2006, the hospital formally integrated the group into its corporate structure as a wholly owned subsidiary. Up until that time, there were affiliation agreements, but we were not formally integrated. And I think that was an important step for us to take. That really made a lot of the discussions in the longer run that we'll talk about later about integrating financials and strategic planning and things like that easier, because people saw this in a different way. And quite honestly, there was some trepidation on the part of the physicians making that step. But the hospital chief CEO was very reassuring, and people trusted him personally, and therefore put put that ahead of any fears that they had. Again, 2009, more integration. We opened an inpatient unit in Waterbury, Connecticut, at St. Mary's Hospital. That was a result of both St. Mary's and their competing hospital in Waterbury agreeing that the condition upon which they would both close their inpatient units was if neither could have the resulting unit, and we were able to come in and say, well, we can operate a unified pediatric unit, and then the only decision was really which of the two to, where to locate it among the two hospitals. In 2010, we integrated a private cardiology group, and then 2011, we integrated the neonatal ICU from UConn Health Center into our hospital, and that was another major step. Finally, this year, within the past 6 weeks, we've jointly recruited a cardiothoracic surgeon with Yale New Haven Hospital. That's an important partnership for us. Neither us nor Yale, without controlling the entire state, have really enough volume to have an outstanding cardiothoracic surgery program. But together, working in concert, we can do that. With respect to governance, and harkening back to slide 22, and the Board of Governance Committee that at the RCSSD Foundation, looking at the list of folks they listed there, the composition of their board and our board is very, very similar. So if you really look at the folks that are there, with the exception of they list 8 clinically oriented physician leaders, and our number is 5. The other difference is the hospital CEO sits on our board and is the sole member of our board, and obviously some of those rights of appointment, CFO, COO, et cetera, fall with that person. Children's is responsible for strategic planning. The hospital is responsible for overall strategic planning, long-term annual enterprise-wide goals and objectives, but there's significant CCSG organizational and overall physician input. I think we counted recently, we just completed our most recent 5-year strategic plan, and I think we had 59 different physicians, including those from the community, involved in some form or fashion, directly involved. The Children's also approves the rolled up budget, which includes the specialty group. There is no direct CCSG representation on the Children's board. And the CCSG board approves the specialty group budget. It monitors our progress against those strategic objectives. It determines faculty compensation, and I think, like was mentioned before, I think that's an important factor for autonomy, for the specialty group autonomy, and very symbolic, important symbolic function to have. The strategic oversight of clinical operations, obviously, to monitor and make progress against those objectives. And obviously the board, as any board's major function, is to hire or terminate the president of CCSG. To date, there has been a non-physician administrator, namely myself, I am transitioning, as you saw in the intro, to the full-time, the marketing and business development role for the hospital. So we're in the process and have been for a number of months now in recruiting an administrator, and the preference would be to bring in a physician administrator in the long run, which speaks to Ken's points about increasing integration of physicians into governance authority and overall hospital management. So moving into what the specialty group is responsible for, and then we'll move on to what the hospital is responsible for. And I think it's important to kind of use this as an example of the level of integration and the level of sort of handing things back and forth. And you'll see as I go through that in many categories, if not each and every one, there's a level of give and take, and even if it's nominally on one side or the other, there's a tremendous amount of integration. So first off, faculty hiring and programmatic services to achieve growth plans is under specialty group management. The development of long-term plans with respect to the rate of hire, the timing of physician hires, is also determined by the group and its physician and administrative leadership. And this is, however, with review by the CFO and the input of the Vice President of Business Development. So, once I make the transition, I will continue to have a voice in that particular role. The group is also responsible for driving the ambulatory geographic growth. Again, significant engagement with the hospital chief operating officer, the vice president of business development, and other programmatic leaders. So when we look at opening new geographic sites, we look at both specialty group and hospital programs. And the term used earlier, the tip of the spear, is certainly what we're accomplishing for both ourselves and for the hospital in terms of it's the physician services that are really going to promulgate growth for the whole enterprise, and why we really need to be driving that ambulatory growth and have principal responsibility. Specific faculty hires, their timing, focus, and programmatic priorities. The plans for all hires are reviewed jointly by both CCSG Medical and Children's Financial Leadership. So we have a small group that consists of the physician and surgeon-in-chief, the hospital CFO, and the president of the specialty group that review every hire and authorize that before we embark on recruitment. Faculty development and mentoring. We'll soon work with hospital organizational staff on a formal leadership development program, and we'll talk some more about leadership development and the importance of it in our continued evolution and where we see the challenges moving forward. I think both for our organization and probably in general. Compensation programs are developed at the group level, both base compensation and incentive programs. So continuing with CCSG administration and what its management is responsible for, day-to-day clinical operations, although we did recently shift line accountability for nursing under uncentralized nursing leadership, so that there's a line for nursing up through the CNO on the hospital side, and professional integration and standards on that front. Doing this effectively requires that nursing management integrates well and has good working relationships and communication with general practice operations management as well. Clinical coordination, although we, again, anticipate increasing support from the hospital quality staff as they grow and as they develop more specific metrics and expertise helping us. We believe that this management structure allows for a good amount of self-determination, flexibility, and also, importantly, engagement and idea generation at the local level within the practice, at the program and divisional level. And as I've cited a couple of times, it includes the engagement of both senior-level physician and administrative leaders. Moving on to further CCSG management, that's actually looking at this, this is, there's a typo in the slide. This should say children's management is responsible for. So I apologize for that. Children's management is responsible for contracting, payer contract negotiations, billing, which is a recent transfer of accountability from CCSG, for benefits administration, HR, et cetera, negotiating for all employee benefits, health, and so on. And human resources, the exception there is physician recruiting and onboarding. I think that both their comfort level in not having that responsibility and the group's comfort level is that we want to be at the front lines of all recruiting and onboarding, and really be responsible for retention. We talked earlier about how important it is to how important it will be to have recruitment and retention, and it really is the most critical. It's an essential resource to have any success. Policies with comment and input by CCSG, medical administrative leaders, managed care administration, fundraising with active engagement and participation by the faculty. Again, this should say children's management, IT support with strong connection to the CMIO, and then marketing, website, media relations, research administration, balanced with determination by CCSG physician leaders with children's appointments for the funding determinations, physician liaison and regional pediatric services to support referral from primary care pediatric providers, and then the modeling and reporting of physician compensation programs. So while we are responsible, while the specialty group is responsible for determination of those programs, the hospital has some measure of engagement and at least implied control in sort of having the reporting and modeling. Challenges and successes in the early years with respect to financial reporting, there was tension, and it wasn't always underlying tension between the hospital and the practice with respect to funds flow and recognition of contribution to the overall bottom line. The practice, the way that we accounted for our financials, we owned many research expenses as well as pretty much all operational expenses. There was a reference earlier to supportive operational expenses. That's not a direction that we've ever taken. And because of that, the practice financials were increasingly dismal because of our all-inclusive approach of expenses. How we address that, we first really clarified the accounting for the funds flow, and then most importantly, we decided if we're all in this boat together, let's roll up the operational financials between the practice and the hospital, combine them, and report them as such. So there's not this, well, the practice is losing money. Well, they're supposed to lose money, and that sort of thing. And then, in general, more explicit recognition for contributions to the enterprise. Further challenges and successes, early recognition by the hospital, again, another theme that cuts across both organizations. Early recognition by the hospital that practice clinical operations management is different, distinct, and that's important. The hospital's allowed, long-term has allowed for a great deal of autonomy in our operations, and it's served us well through the years. The medical leadership has bought into the strategic plan in no small part because of their significant engagement. Then the other thing is engaging medical leadership as well as divisional leadership appropriately, and that's a continuing balance. The process that we used this time, as opposed to 5 years ago, was more. It was a faster process, and it was a little bit more top-down. So divisional leaders probably feel like they need to be more engaged on the ground here, but That's something that we continue to look at. Everyone shares the organization's mission, vision, and obviously strategy, and the culture has continued to merge and really is reflective of our strategy. I think we've really seen a difference in that over the last couple of years, and the statement which many of you have probably heard of, culture eats strategy for lunch, applies here as well. Other quick observations on the current state, our roots in the product of sequential integrations. We continue to evolve from one of divisional autonomy, which we really started with by bringing all those various entities together, to one of true organizational focus. I cited before the relationship and responsibilities between divisional leaders and organizational senior medical leadership continues to evolve. I think Ken cited earlier the potential for overlap and even confusion. So we continue to refine that, and I think those are important matters that I think anyone in our shoes, anyone that's looking at a similar structure, needs to pay close attention to. Again, the role of division chiefs, and we're really looking at having some leadership development programming, goals including common expectations, accountability, leadership skills, and qualities, so that across our divisions we've got not just a common organizational culture, but a common experience and common way of approaching things. Broadest statement is collectivity wins, and I think that's an important lesson for our extra-organizational relationships as well as internally. And will help us moving forward, particularly as healthcare evolves and moves into who knows where, depending on where we go in November and so on. Just to wrap up in the last minute or two, what the future might hold, I think there's going to be much more complex and challenging compensation within the organization, how we compensate our physicians and providers in general, and what those reward methodologies will be. Certainly need to reflect quality and service factors as well as other non-clinical considerations, and the major question of how clinical productivity will be measured in the future as the reimbursement methodologies evolve will further complicate matters in terms of internal compensation. How to most effectively collaborate with referring primary care providers and pediatricians, an issue of ownership versus indispensability. Should we go out and own providers, or should we make ourselves indispensable to them? Effective partnerships with other institutions is going to be incredibly important moving forward. Finally, how to remain attractive to recruits in an increasingly competitive environment. Cited this before as an important natural resource of success. And organizational culture, professional satisfaction, development for individuals, and an attractive environment for both clinical educators and researchers alike, and balancing those cultures and balancing your number of recruits along those lines. How to deliver care not just better, but in new ways as the environment changes and reimbursement changes. And then finally, having the organization's culture, its strategy, and its leaders' ability, back to leadership development, to execute, has to keep up with change, and as change accelerates. And the statement that we believe that natural selection favors adaptation, not simply the biggest or the strongest. Otherwise, we'd still see dinosaurs or Tyrannosaurus rexes around. So with that, I will close, and I think Ken was going to share with us some conclusions based on the presentation.
Thanks, Dean. I think just to sum it up, what everybody is really locked on, and I think it's true, is that we're going to see more and more of this with the pressure. And then what both you all demonstrate is really that it is going to be the unique structure that your market drives and the partners that are in the discussion that's going to really be important, that we look at that unique structure. So with that, I think we'll close the webinar and thank our audience as well as our presenters for sharing their thoughts and experiences regarding physician-hospital alignment strategies in pediatric healthcare. While we have several questions, I think we're going to have to get to those offline to you. And this will conclude our webinar, but please take a moment to complete the electronic survey upon exiting your session today. We hope you will join us for upcoming programs in the Pediatric Business and Healthcare Delivery Series. Registration for the next session in mid-July will be open in the coming weeks. If any of you should have any further questions about this session, the series, or subject matter in general, please feel free to contact Ken Rorta or Mark Waxman. Their contact information will be found on page 2 of the handout that you received. Thank you all and have a great afternoon.